Good morning, everybody. I'm also very thankful for the ESE and also to all the patient organizations who are working so hard on this important topic that remains the last endocrine deficiency disorder that is not currently in routine appropriately treated, I believe. We have a very interesting program ahead, so we cannot spend too much time talking before the talks. We have now Dr. Tanya Sikier, who is a very experienced endocrinologist and clinical researcher, specifically in the topic of hypoparathyroidism, despite her young age already for quite a long time. And we are very much looking forward to the talk. We can accept questions afterwards, but you can also already type in questions in written form during the talk. So please go ahead and start the talk.
Hi, my name is Tanya Sikier and I'm a medical doctor from Denmark. And first I'd like to thank the organizing committee for inviting me to give this talk. I'd like to talk about hypoparathyroidism, long-term issues with treatment and disease, and how to prevent and manage them. Before we go ahead, I just gave a brief talk about the PTH and calcium homeostasis. And this is in order to better understand the complication in the different organs if we know how it's working. So what we're talking about is the parathyroid glands. They are situated behind the thyroid gland on the neck. And on the cell surface, it has the calcium sensing receptor, which is a kind of a thermostat that measures the calcium levels in the blood, and then it reacts to that. So in case of low levels of calcium, then it is sensed by the calcium sensing receptor, and the production and secretion of PTH is increased. But in case of hypoparathyroidism, as we're going to talk about now, then there is low or no production of PTH. And when there is no PTH, then there is no activation of the PTH receptors in the bones. The bones are our main source of calcium, so in case of low levels of calcium in the bloodstream, then the bone resorption is activated and we can mobilize calcium and phosphate from the bone tissue. But when we have no PTH, then there's no release of calcium, and then the bone mineral density increases, which I'm going to talk about later on. Looking in the kidneys, then when we don't have any PTH, then there is no activation of the 1-alpha hydroxylases, and that is a bit complicated. It just means that native vitamin D is activated to active vitamin D, also called calcitriol, in the kidneys. So when we have no activation of the native vitamin D to active vitamin D, then we have a problem in the intestines, because the calcium that we eat as supplements or in our diets needs active vitamin D in order to be absorbed from the intestines into the blood, into the circulation. Sorry. So it means that when we don't have the PTH, then we have a reduced calcium uptake. Furthermore, in the kidneys, it also reabsorbs the calcium, so we don't lose a lot of the calcium in the urine. But with no PTH, then we don't have the reabsorption of calcium, and we will have high levels of calcium in the urine. So the conventional treatment with calcium and active vitamin D, well, the active vitamin D analogs works on bones and calcium uptake in the intestines, but doesn't work the other places. And then it's important to notice that this is a disease, not a disease where we need a lot of calcium. We are not missing the calcium, we're missing the PTH and the active vitamin D. So if we eat enough calcium in our diet, we might not need supplementation. Treating with PTH, on the other hand, then it works on bones, on reabsorption of calcium in the kidneys, and activation of native vitamin D. And it also works on the PTH receptors in other tissues, such as muscle and brain. So looking at the bones, as I just mentioned, bone is our biggest calcium reserve, and that's where we go to when we have low levels of calcium in the blood. But the release of calcium from bone is dependent on PTH and activated vitamin D. So if we have no or low levels of PTH, it will result in inactive bone. And this figure here is showing a circle of bone resorption going down in the depth, and then bone formation, building up new bone again. So the first figure is in a normal person, and when we look at the elongated one as a second figure, it's in a patient with hypoparathyroidism. So as you can see, it's a very slow with the bone resorption and formation, and much more inactive than in the normal bone. So what does this mean in the bone? Well, it means that when we don't release calcium and phosphate from the bone, then we end up with a high BMD, which means a bone mineral density. So we have thick and very dense bones. We measure that by a DEXA scan, and the measurement will be given in a T-score. So what we can be afraid of is that we kind of have old bones and we have a reduced repairment of these bones. So what does that mean? Well, first here, this is a figure showing in the top of the patients with hypoparathyroidism and below of a healthy control. And as you can see here, we have much more material, calcium and phosphate per square centimeter in the hypopara patient compared to the control. So back to the bone quality. So do we have a risk of fractures when these bones might be old? There's a few studies that have shown an increased risk of vertebral fractures, as shown here. So you can see with the arrow we have a vertebral fracture, but other studies have not found that there is an increased risk. There has been a study where we have compared, it's a registered study where we have compared patients with hypoparathyroidism to controls, and we didn't see any difference in fractures except from the forearm fracture. And it showed that in patients with post-surgical hypopara that there was a decreased risk in forearm fracture, and in the non-surgical increased risk in forearm fractures. Looking at the kidneys, then the lack of PTH will result in higher levels of calcium in the urine. And we know that conventional treatment might increase this urinary calcium. And this is because we do give a lot of calcium as supplementation. And if it's not reabsorbed, then it will be in the urine and thereby high levels of urinary calcium. From registered studies, if we compare patients with hypopara to patients with healthy controls, then we find a 5 to 6-fold risk of renal insufficiency in patients with hypopara and almost a 5-fold risk of kidney stones. But there's a big difference between the studies that have been performed. So if we look here about in all of the studies where they have looked at patients with hypopara and chronic kidney disease, we can see that the true value is probably in there between 5% and 41%. Then I'd like to talk a bit about calcium in the muscle and nerves, and I'm not going to go into details with this figure. It's just I want to emphasize that calcium is very important when we have a muscle contraction. It starts with the neurotransmission, where this is the neuron activating at a muscle site, and in this activation then calcium plays an important role. And again, when we have muscle contraction and muscle relaxation, calcium is also very important. So calcium is important for nerve transmission and muscle contraction. And then as another thing, we know that there are PTH receptors in the muscle tissues, and they will not be activated when we only treat with conventional treatment. So what do we find in muscle and nerves? Well, there have been done a few studies on clinical studies on muscle strength. One have been performed at our site, and we found a reduced muscle strength when we measured it in this chair when we measure muscle strength. Another study have found a reduced hand grip strength. If we do activity tests as timed up and go and repeated chair stands, then patients with hypoparathyroidism does take an increase, longer time, to perform these tests than healthy controls. A few studies have measured on myopathy, and they haven't found any connection with hypoparathyroidism. We also see muscle cramps, muscle fatigue and weakness, and muscle spasm, and as far as tetany. And this is a picture of a patient where we kind of irritate the nerves by compressing with this blood measure thing, and then you can, as you can see that in the hands, you provoke a cramp. This is a big questionnaire study where they have asked a lot of patients with hypoparathyroidism into different things about their activities and mental well-being. So here they have asked about how much hypoparathyroidism has an impact on different activities. And in those activities which requires muscle strength, like exercise and gardening and other yard work, well, up to half of these patients indicate that there's a significant impact on that activity. Looking at the heart, then the heart is also a muscle. So if we have low, either acute or chronic low levels of calcium, then it will affect the heart. It can result in arrhythmias and heart failure. The good thing is that when we correct the calcium and the calcium levels is normalized, then it's often a reversible situation, and the heart gets better. But from registered studies, there is indication that hypoparathyroidism is associated with ischemic heart disease. But it's very important to emphasize that there's very few data on hypoparathyroidism and cardiac complications. So looking at the brain, well, there have been a few studies with groups, but more studies with single or few patients showing by CT or MRI scans that there is calcifications in the brain. It has not been clearly shown that these calcification has an impact on cognitive function or quality of life or other things. And the calcification is shown here. We have performed an MRI study where we have found structural changes in the brain, where we found the size of the hippocampus smaller in patients with hypopara compared to healthy controls. And then several studies have shown that there is indication of a reduced cognitive function in patients with hypoparathyroidism, and quite a lot of patients describe their cognitive function as having a kind of brain fog, so the brain is not working properly. So back to this questionnaire study where a lot of the patients complained of fatigue, inability to focus or concentrate, memory loss and forgetfulness, and sleep disturbances. Looking at quality of life, there has been quite a lot of studies now looking at the quality of life, both with very general questionnaires, but also with more disease-specific questionnaires. And a lot of these have shown that patients have a more reduced quality of life compared to healthy controls. This is a study performed in our group where we looked at healthy controls as those in the light gray, and in the darker gray it's patients with hypothyroidism, so low thyroid hormone, and then the black, which has both hypothyroidism and hypoparathyroidism. And as you can see here, low scores is low quality of life. So the patients with both diseases is much more affected than those with just hypothyroidism, and especially compared to healthy controls. And back to the questionnaire study, they also found an impact on well-being and on social and personal relationships. So how to avoid this complication? It's important to keep blood calcium in the lowest or just below the reference range, to keep urinary calcium levels normal, and to avoid high levels of phosphate. And how to do so is to have regular blood samples performed with calcium, phosphates, kidney function and magnesium, to avoid a high dose of calcium, to take calcium with meals, then it works as a phosphate binder, maybe to use thiazide diuretics to lower calcium loss in the urine. And it's important to have normal vitamin D and magnesium levels. And how to detect the complication? Well, in bones, in case of sudden back pain, then consider an X-ray if suspicion of a vertebral fracture. In the kidneys, it's important to, from time to time, to collect 24-hour urinary samples to quantify the urinary calcium levels, and to do ultrasonic or CT evaluation of kidneys in case of decline in renal function or abdominal pain with suspicion of renal stones. And last, looking forward, well, conventional treatment with calcium and active vitamin D does not restore the effect of the missing hormone PTH. And conventional treatment aims to relieve the patient of symptoms of the low levels of calcium. So in future treatment with hopefully replacement of the missing hormone PTH, it might reduce the risk of complication, target the organs with PTH receptors that are not affected by conventional treatment, and hopefully to restore the reduced quality of life. Thank you.
So thank you very much for this interesting talk. I now hand over to Tanja Richter. So you see we have a Tanja Day today. She is very active and has been very active in the German Netzwerk Hypopara, in the German patient organization, and will introduce our patient speakers in the second part of session 1.
Thank you very much, Karin. Hi, I'm Tanja with the German Hypopara Network. And now we will focus more on the patient experience. So what's it like to live with hypopara long term? We'll have Stella first. Stella is the mother of a child with hypopara. She's a member of Parathyroid UK and a member and volunteer of a Romanian patient organization for primary immunodeficiencies, which is a part of a larger international organization for primary immunodeficiencies, which is called IPOPI. Stella is also a patient advocate for the thymus transplantation program at Great Ormond Street Hospital in London. She's the founder of online support groups for parents of children who need a thymus transplantation internationally, and also on a national level online support groups, such as one called 22Q11 in Romania, and children with feeding tubes in Romania. So she will speak first.
Hello everyone, I'm very excited to be here today. Thank you for inviting me to talk. My name is Stella Pârvu. I'm originally from Romania, but we now live in the UK. I'm a mother of a 12-year-old, very smart, very kind and wonderful boy who was born with hypoparathyroidism along with other diagnoses such as severe primary immunodeficiency and others. Today I'm going to share with you our 12 years of experience in living with congenital hypoparathyroidism from a parent's perspective. I'm going to share my screen with you now. There are different types of hypoparathyroidism depending on the causes. So congenital from birth, that usually is from a genetic cause, acquired, or which is usually from due to damage or the removal of the parathyroid glands. This is the most frequent type of hypoparathyroidism. And there are other causes as well, like autoimmune or associated with other disorders or with idiopathic, which means that the doctors do not really know the cause of your hypoparathyroidism. Today I'm going to talk about congenital hypoparathyroidism. My son has congenital hypopara, meaning he was born with it due to TBX1 gene mutation. My son's diagnosis is complete DiGeorge syndrome, meaning he was born without a functional thymus. Thus, he had no naive T cells, resulting in severe immunodeficiency. He has had a thymus transplantation at Great Ormond Street Hospital a few years ago. The thymus and the parathyroid develop in the third pharyngeal pouch in embryos, so my son's TBX1 gene mutation caused him to have no thymus and no parathyroid gland. When explaining the condition to family and friends, I usually compare it to diabetes because everyone has heard of diabetes. So in people with diabetes, there's a lack of insulin, and people with hypopara, there is a lack of PTH, parathormone. The insulin regulates the sugar level in the body, just as PTH regulates the calcium level in the body. I want to mention that hypoparathyroidism is the only endocrine disorder where the replacement of the hormone is not the standard of care. We just use short-term management of symptoms with active vitamin D like alpha-calcidol, calcitriol, and calcium supplements and hope for the best. There is no home calcium monitor available, so this is forcing parents to become human calcium detectors and frequent hospital visits for blood tests. And in 90% of the times, no one believes how serious and life-threatening this is, as it's just calcium, isn't it? As I've said, calcium is important in the way the muscles and the nervous system work. So if the calcium level goes down, my son could get low calcium symptoms. I have highlighted these in 3 different colors. The reason is that these actually happen in the order of these colors. So when calcium starts to go down, he would get the initial signs that could easily be overlooked. So these, the symptoms that are highlighted in green: increased irritability, change in behavior patterns, anxiety, depression, fatigue, lack of concentration. As his calcium goes down even further than that, he would get the symptoms that are highlighted in yellow, like irregular heart rate, pain in his chest when taking deep breaths, several daily persistent episodes of hiccups, muscle spasms, cramps, blackouts, brain fog. And if the calcium goes even further down, he would get stridor, blockage in the throat, difficulties breathing, laryngospasm, Trousseau sign, that's a hand position when sleeping, tetany, seizures, and this is life-threatening. The most frustrating part is that we need to keep the calcium level at the lower end to protect his kidneys. Therefore, many times he's having occasional symptoms as the one in green, which are usually dismissed by the doctor as seen not serious. And these are mistaken also by his age, a teenager feeling anxiety or tired all the time, or occasional lack of concentration, and everyone would say, oh, that's normal. But these actually dramatically affect the quality of life, and these are not a part of his usual behavior. Now, some of the challenges we face on a daily basis, getting doctors to take the first signs of low calcium seriously. These are easily confused with normal behavior due to age. My son had signs of low calcium since birth, which I have noticed, but I couldn't identify as low calcium symptoms like tremors, lethargy, very poor feeding, vomiting, muscle twitches, unusual position of the hands and legs, irritability. Everyone, of course, has dismissed my worries and considered that I was just a first-time young mom, unexperienced, and I was over-concerned about my baby. As his calcium got lower, things got more complicated. He got admitted in the hospital at 4 months old. During our hospital admission, while I was with him in the room, he started having seizures. I called the doctor, but the doctor said when the doctor came, my son stopped having seizures. So the doctor considered that I was overreacting, and he was admitted with pneumonia. So she said, of course, he has difficulties breathing because he has pneumonia, but it was more than that. This happened a few times. My son would get seizures. I would call the nurse or the doctor. By the time they got to our room, he would stop and no one believed me. On that same day, the doctor got very annoyed because I was calling her for nothing, and asked me to leave the hospital and leave my son in the hands of professionals because, in her opinion, the lack of sleep has affected me and I was seeing things, as she said. I had no choice and left, only to be called back in, as my son started having continuous seizures, one after another, and no one knew what is causing this. I came back, and during that night, he had more than 30 seizures per night, each one leaving him purple and unable to breathe, muscles contracting together, tetany, excruciatingly painful. This was Christmas Eve, so my son's first Christmas. We had no idea if he would survive that night. Doctors had no idea what is causing this. They were chasing other leads like neurological issues, epilepsy, heart issues, but no one actually thought about calcium. His calcium level got as low as around 0.5, and it is a miracle that he survived. So other challenges that we face, getting people to understand that it's not just calcium and these symptoms are serious and could be lethal. Identifying the first symptoms correctly and going to the hospital on time. Parents are human calcium detectors, as I've said. A huge burden of not waiting too long, but also the fear of making a mistake, because if you make a mistake, the doctor might not believe you next time. And no more good veins for blood tests. He has 6 central lines. He has had 6, taking bloods is really difficult. We need to keep the calcium level at lower end to protect his kidneys, resulting in low quality of life. Complications due to the current treatment, like nephrocalcinosis. Due to medication, he sometimes gets high calcium level. Very high calcium is life-threatening too. So the symptoms for high calcium are high heart rate, passing large amounts of urine, feeling very thirsty, dehydration, confusion, agitation, muscle spasm, bone pain, weakness, irregular heartbeat, difficulty thinking and speaking, extreme dizziness, fatigue. Keeping his calcium levels in the range that his body tolerates is tricky. Therefore, no, it's not just calcium. This is like telling someone with diabetes it's just sugar. We have another issue to keep an eye out. That's the phosphate level. The excessive phosphate we take with food usually gets out of our body through the kidneys. The PTH takes care of that, but without PTH, parat hormone, the phosphate in the food builds up and it binds with the calcium, creating calcifications where we don't want them to, like in the kidneys, creating nephrocalcinosis. Tips for other parents with children with hypopara. Continuously educate yourself about your child's disease using only trusted resources like medical journals, medical conferences, patient organizations. Follow their social media, their websites for events and register for them. I want to add here that in order to understand and help my son, as he has this ultra rare disease, I had to become the expert. I have participated in more than 15 medical conferences around the world, both in person and online. And please also volunteer in local existing patient organizations where you will find your tribe. You will find the people that are going through a similar journey, and this is very important. Trust your instinct. If something seems wrong, it most likely could be. Everyone around you, including doctors, might dismiss your initial worries. Family and friends might try to comfort you by saying that some symptoms you notice are normal for age or social context. Advocate for your child. Make sure your doctor is following the recent clinical guidelines in monitoring and treatment. Remember the symptoms and write them down as you notice them. For low and high calcium, even if they seem insignificant or too mild, inform people involved in your child's care about these symptoms. Tell your doctor if mild symptoms are continuous and affect the quality of life. Good communication is important, but please remember that you do need to keep the calcium level on the low end. Thank you so much for inviting me, and I do hope that parents listening to this presentation have found it useful. Thank you.
Thank you very much, Stella. We will now continue with a couple. They are Jane Compton and her husband, Steve Compton. Jane is originally from Wales and she's a trained nurse. She has been married to Steve for over 35 years. In 2013, Jane had surgery to remove 3.5 overactive parathyroid glands and was left with hypopara. Jane is a member of Parathyroid UK, and she supports patients with hypopara and attends conferences to raise awareness about parathyroid conditions. So Jane and Steve.
Hello, I'm Jane. This is
Hi,
Steve.
I'm Steve.
Steve, my husband. And basically, we're just going to give you a little background about what it's like to live with chronic hypoparathyroidism as the patient and as the long-suffering husband. No, seriously. Okay. I became hypopara in 2013 when I had all my parathyroids removed because they were all hyperplastic, and I had 3.5 removed and I had half left, which never worked again. So then I was rendered hypopara after quite a few years of very high calcium, and now had the opposite problem with very low calcium. Okay, so my story starts when I became hypopara. It was a huge shock, having always been active and busy, 4 children, nursing job, no idea how important calcium is and how, when it's wrong, it impacts everything that you do. So in the early days, so that's post-surgery, I had 2 years of really unstable calcium levels, which required a lot of blood tests and some hospital admissions, you know, and it was really awful. And how that impacted on me was I couldn't be a wife, I couldn't be a mother, I couldn't be a nurse. Everything that I had done previously to that was a real struggle, and I was depressed. I was very hard to live with.
Oh, I wouldn't have said that.
No, and it was not like me at all. I mean, you know, I've always been quite positive. It was really a massive change, and I guess like any chronic illness, you have to come to terms with it, and that took me a while. And I think, you know, the fatigue was terrible. I couldn't manage to, on some days when my calcium was very low, I couldn't manage to get out of bed. I mean, I did get out of bed because I had to, but it was really difficult. And I honestly thought life wasn't really worth living. It was so awful in the beginning. However, I'm pleased to say I'm in a much better position now because for the last 9 years, so after 2 years of unstable levels, I got PTH injectable, which has definitely stabilized my calcium much more. So I'm not forever in hospital because we don't have home testers like a diabetic. you can test your blood, sort your glucose out, adjust up your meds, and you're not forever working in the dark. But
it's not instant as well, is it? When you
no,
change,
it's not instant. So when
if
your
calcium's low, you have more calcium, and
it takes a while to come back up.
Come back up.
And you know, you're pretty much out of it when you have a hypo. You're so unwell. You know, it affects everything. It affects all your systems. Your heart goes fast. You know, you can't breathe properly. You feel like you can't breathe properly. You're just a mess. So I think I'm definitely an advocate for PTH because it's really helped me. It's not a fix-all. It doesn't fix everything, but
makes it more stable.
Makes it more stable. Yeah.
Just more stable.
When I was unstable, our kids were younger. They were kind of school age, young teenagers, and it just impacted everything. I couldn't run them to guides or cadets, or on the days I was always like work. I had busy clinics. I was a practice nurse. You know, I became unreliable, and I've never been unreliable. I loved my job, and I'd have maybe 30 patients booked in a day, and they all had to be rung up and cancelled. And this used to happen a lot. And in the end, I couldn't cope with being unreliable. I couldn't cope with the work because my brain wouldn't function. I couldn't think straight. You know, all these things just impacted everything. And for you, it was really hard because, you know, he was used to me being, you know, very active and very busy and reliable, and you
took a long time to adjust.
Yeah,
really.
and we had to work through that as a couple, and it was really hard, really difficult. But as I say, I'm much better now on PTH, and although it's not going to cure me, does make it all more manageable. And it's the closest thing I'm going to get to Mother Nature, so I am actually very grateful for that. Now, as a couple, we've had to, and as a mother, wife, we've had to, you know, adjust up. So there's lots of things we can't do together, which makes us sad. Like we always wanted to do walking holidays.
That was the plan.
Yeah,
walking holidays.
If he walks the dog, he does a 3-mile route march. Now I can't do that with him because I'll be exhausted for the rest of the day, and there'll be a price to pay. Whereas I'll amble around the park with the dog. So even things like simple as going for a dog walk, you know.
It's either a route march or an amble to the gaff.
We have to compromise. Yeah, we might just do a short walk because I can't do the long walk. But, you know, on the positive, I do what I can, and it's good to keep gently active. But you have to accept that if you're going to do something, if I have a really busy day coming up, then I have to pace myself, and I have to allow for that, and maybe have an easier day before and a couple of easy days after. It's really hard.
Slightly adjust calcium a little bit. If you know it's going to be a busy day,
take a bit extra,
take a bit more,
eat more calcium-rich food, and try.
But you can't do too much of that, so you have to be.
Yeah, you have to be careful. I still have regular blood tests every month, which I'm grateful for because it stops me stabbing around in the dark. And as I said, I am much more stable, and life is definitely much better with PTH. You know, we've adjusted up ourselves. Our kids understand that sometimes I'm, you know, and close family mainly understand. Sometimes they don't. They might think, is she all right one day and not so much the next? But that's just part and parcel of the nature of the disease, the condition.
But it was just before PTH, you're chasing it up and down all the time. There's always one step behind it.
Yeah.
So it's high or too low, and it's always, you have a blood test and it's a day before you get the result. So
it used to be longer.
Constantly up and down.
Yeah, but now what I would say, to get your doctors on board, because my consultant, she wasn't a hypopara expert, not at all, but she was very good at listening to me, working with the guidelines. The big thing is to advocate for yourself, learn about it. The website, the hypoparathyroid.co, is amazing, and I'm so grateful to Liz Glenister who started it, and many, many more. What a lifeline, because you do feel isolated, you do feel alone, even when you've got a good family like I've got. You know, you feel desperately alone when you're feeling that ill, and no one seems to get it. That's the thing. But have come to accept now that if I get the care and the treatment that I need because I have advocated for myself with, you know, because of Hypopara giving me the knowledge and giving me the impetus to do that, rather than just me stabbing around on my own. And I guess being a nurse made it easier to talk to doctors because I'd always talk to doctors in my working life. But even if you're not medical, you know, all the information is there. Get it all on board, take it to your doctor, get them to work with you. And, you know, I think you will really benefit from that. And obviously, having a good husband helps. I can't guarantee that for all of you, but you know, we've worked through this and I'm sure you can too. So, what other things can we add?
Don't know, you just have to change. You can still do loads of things, can't you?
Yeah.
Just,
you have to...
you know what your limits are, really.
Exactly.
Like we have a
limits.
camper van, so we go off in that and we'll just go touring around and just nice, easy stuff, really.
Yeah. And, you
it's
know,
all quite agreeable.
Yeah, if we, you know, if like I used to go skiing, I loved it. I wasn't very good, but I did love it. And I couldn't possibly do that now because I just haven't got the strength. And I know I look all right. I totally look all right.
Or flying a long haul flight.
Oh, long haul flights,
they're
another nightmare.
Not a good idea.
No,
really.
because a couple of times I've collapsed on the aeroplane, my calcium's dropped on board. I feel very, you know, nervous about flying long haul. But some people, we're all different. Some people are fine, others are not so. I mean, like some people are fine on the drugs, but I wasn't. They didn't seem to work for me. So, you know, I think as with any long-term condition, figuring it out is hard, but eventually life does
you get into a pattern or a routine, don't you?
It does get better.
You learn to manage it.
You learn to manage it. Yeah, you learn to manage it. We have. So you can too.
Good
Okay.
luck.
Thank you very much, Jane and Steve. And now we'll have the third perspective, the daughter's perspective. We'll now very quickly hear from Danae. Danae grew up in France and is now a family medicine resident doctor in Canada. When she was a child, her mother was diagnosed with hypopara, and Danae will present her perspective as a now grown-up daughter. And this is Danae.
Hi everyone, my name is Danae. I'm a family medicine resident doctor in Canada, and I grew up with a mother that was diagnosed with hypoparathyroidism. So I was about 10 years old when she was diagnosed, and needless to say, it was a very, very challenging time, not only for me, but also for her. I think when you're so young, one of the most challenging aspects is that you don't understand why your parent is having these reactions or why they're having these symptoms. So for me, for example, I recall not understanding why my mother was so tired or why she was having these anger outbursts or these depressive symptoms. And some nights I found myself having to cook my own meals or having to have friends drive me back home because she was too tired to do so. And I think it was very challenging because I just didn't understand where these symptoms were coming from. Now I can truly say with some hindsight that what my mom went through was incredibly difficult because not only was she having to handle these new symptoms and also navigate the unknown of this new diagnosis, but on top of that, she also had to make sure her children were okay. Now that I've grown up, I can genuinely say I've gained a better understanding of the disease, of where these symptoms come from. And I think that the research that has been put into hypoparathyroidism has been truly invaluable in the sense that it's brought more answers to the questions patients might have. And I think a moment of realization I had when I grew up was these symptoms and these reactions, they're not secondary to who she was as a person, but they were truly secondary to the disease. So when you help the disease, you help these symptoms. And now that I'm 26 and I'm a doctor and I've truly seen both aspects of the spectrum, being a doctor, but also being the patient's family, I would give the piece of advice to doctors out there to just take that extra 15 minutes, that extra 30 minutes if needed, to answer the questions your patients might have, or even the questions their families might have. Because it might not make a big difference in your day, but trust me, it makes the world of a difference in the day of your patients, in the day of the patient's family. And I think it helps them get some answers to their questions and understand where these symptoms are coming from. So please take the time. Thank you.
Thank you very much to all the patients, and of course also to Tanya Sikier for their presentations. We will now continue with a Q&A. One thing though, Jane and Steve couldn't be here, and also Danae is in a different time zone, so she couldn't be here either. If you have any questions for a couple, Natalie and her husband Christoph thankfully said they would be here for that, and they would be able to answer any questions directed at a couple. Just a quick word on Natalie, who you've seen before, and also, of course, in the previous two patient forums that we had. So Natalie had surgery for thyroid cancer in 2008, which resulted in her developing hypopara. The severity of her symptoms put a significant toll on her and her family, eventually leading to a divorce in 2009. She has since remarried and has been with her husband Christoph for over 10 years. And Natalie is also the co-founder of Hypopara France, which is one of the patient organizations you've seen at the very beginning on the slide. Okay, then Karin, maybe you can ask the first question.
Yes, so thank you all for being here. And I think we have a lot of questions already and need to move a little bit quickly. So maybe, Tanya, one question directed at you specifically is, for patients with hypopara, is there an imaging marker more specific than neuropsychiatric tests?
No, unfortunately, we haven't found it yet, but I would love to. That's why we're doing these studies on MRI scans, to see if we can actually somehow find what is the background for this brain fog. And so, yeah, that's my main question for the moment.
Yeah.
But we haven't found a specific marker, but we're still looking into it.
And also related to the question, is brain fog reversible with treatment?
Well, that is hopefully something we will be looking into. We are planning a study to see in some of the patients that have had PTH treatment, if we can do another MRI scan in these patients to see if there is reversible changes. The changes are reversible.
In your clinical expertise, when patients are treated well, it usually improves, no?
They do. Yeah. But it would be so lovely if we can actually show it, because that would make a world of difference, especially with being allowed to treat with PTH, because it's expensive treatment. If we can actually show that this does make a difference, that we can actually show it physically, then it would be a very good argument for the treatment.
For the reimbursement, yeah.
Yeah.
So maybe Tanya Richter, would you go over and discuss the work question with our patient and care givers?
Yeah, okay. Yeah, ability to work. Are you more at risk for being unemployed? From a patient perspective, I personally know people that can work just fine, can do 8-hour days. And I know a lot that can't. I'm not sure if there are any studies. Natalie, do you know of any studies?
Oh,
the Norwegian.
The Norwegian study, they actually looked into it. Marianne Astor looked into it, and she found that 40% of patients with hypopara was unable to work, and in the general population, Norwegian population, was 14%. So yes, they found in their registry work that there was the workability was affected.
And in that questionnaire, did you check if it was full-time and the people that could
They,
still
they
work?
looked both the full-time and they were actually looking at those needing of social security. So they looked at if they had to be supported full-time or just part-time. So.
And if I remember correctly, also 80% of those who worked said that hypopara decreased their work productivity.
Yes.
So it quite substantially does, and we know that, yeah.
Mm.
Also, maybe Selma, who asked this question from Austria, please contact me. We have some additional exams that are being done now where you may be able to participate. So maybe write me an email. Other questions, we have a lot of novel questions. Is iron deficiency related to hypopara?
Not to my knowledge, no.
So I can just say, I don't know, I don't think it's related. We don't have the data, but of course, because it's often premenopausal women, there is a large overlap. So it should be looked for and treated accordingly, but it has not much to do with hypopara, but can be similar with some symptoms like fatigue, etc. So pain in the finger joints after waking up is another question. Is that something you have experienced as patients?
I have more like the hands that are like tingling, like more cramped hands in the morning. Regularly, it seems that like the calcium seems to drop during the night a little bit more, and I feel it more in the morning. I've heard a lot about people having more pains in the morning as well. Tanya, if you would like to.
I personally don't. Yeah, no, if I have something in my hands, it's more the tingling that we all know.
Yes.
Yeah.
And I don't know if Stella, with your son.
Not that I know of. No, not in the mornings, but I have observed some symptoms over the night, as in the position of the hand sometimes when he's sleeping. So definitely overnight the calcium drops a little bit. And he sometimes wakes up in the morning very tired and irascible, but he hasn't complained of any pain. Just usual over the day, sometimes he gets leg pain and muscle cramps, but not something that happens only in the morning.
Yeah. Some patients complain to me, you know, in the morning when we wake up and we stretch a little bit, that they immediately get cramps. So they just avoid doing that. So there's some specific morning symptoms I've heard of. Then we have a question about calcium home tester. Any news there?
Not that I know of.
So in Norway, apparently there is one that can be given home to their patients. Also in Austria, we had a coffee machine size thing that was being tested, but eventually they found out they can't give it to patients. So I think there is really, really great need for that. And maybe we really should also work on communicating this to the companies that could develop such devices. Because of course, a blood gas analyzer, which is of course a large coffee machine or two maybe, could do home testing also with capillary blood. Stella, have you had any experience or seen something?
No, unfortunately, we don't have access to any type of home calcium monitor, and this is really frustrating from a parent's perspective, because when you're the patient, you know your symptoms, and usually I can see that mainly we have adults who are responsible and more aware about their symptoms, but in children, it's so difficult as a parent to realize what are the first symptoms of low calcium. And as I've said, over time, I had to become a human calcium detector. And as a parent, you need to do that. But sometimes you can make mistakes, and sometimes you can consider a symptom as being a low calcium when actually it wasn't. But you just have to observe and do a lot of observations and write down the symptoms, and over time you just become the expert.
But as you said, there is this comparison between type 1 diabetes and hypopara, and I think we will be getting there, but it takes just much longer than we all would wish for. Tanya,
I just saw Liz in the chat said that the UK home tester exists, but the trial is on hold for the moment. And someone from Ireland said they got this iStat. iStat is basically this like brick size tester. They got an iStat funded in Ireland for capillary testing. This is just, you get the ionized, I think.
And we had met a person in Portugal. She had a dog that could sniff her calcium.
Okay.
Yeah, it sounds so funny, but you know, for there are dogs for blood sugar. So apparently they can be trained for that too.
Yep. Well, it wasn't trained, it did it on its own, but it
Oh, wow.
Karin, can I add something?
Yes, sure. So Andrea from Italy.
Of course, because in our university, we are working so hard in trying to, to make something that can measure calcium without any drop of blood. So a kind of a non-invasive test to evaluate the ionized calcium. Of course, work in progress, and hopefully in 6 months I will present our data on international congress. So finger crossed about this new kind of technology, even without punching fingers like diabetes.
Okay, excellent. Also, we have a comment from Ireland. Someone, Deborah, got an iStat funded for capillary testing, and it was a game changer for her. So also very important for us. Thank you for this information. Then we have 2 more questions regarding brain calcifications. Do they get worse, and is there treatment?
For now, there's no treatment, not known. What we normally say is that we need to keep the calcium phosphate product as low as possible. So we need to be careful with both the calcium levels, but also the phosphate. I only remember, I think there is one study from India where they looked at the longitudinal data on it, and I think they were getting worse, but it's a long time since I read that paper, but I think that's the only paper I read where they rescanned the patients. What you need to bear in mind with the classification is that this is also found in other patients than patients with hypoparathyroidism. So there's a big study from the US where they actually looked at CT scans from patients who have been in an accident or something like that. And they did find classifications in other patients than patients with hypopara. And again, some of the patients that I have that have quite a lot of classifications, they have normal work, they function normally. So this is a finding that we don't really know where to put and what to do about. So if you know that you have classifications, you shouldn't be that worried, because it's not linear with cognitive impairment and things like that. So it's a very difficult complication to understand for us for now. I hope that answers the question.
So it shows that we have so many more questions that we want and need to work on. Also, not a question from the chat, but an appeal for all of us to just send out regular information and make the condition more known. And I think this whole morning is one activity that should help there, and to campaign also within our systems and our societies and our countries to make hypopara more known among the medical community, but also among the patients and their families. So thank you for that. One question was also regarding menopause. Is there an overlap? How can we differentiate symptoms? Maybe Natalie, you are nodding. Do you want to say something?
This has been like, there's going to be some things that are going to be checked out because there are studies out there that do show that in PMS, premenstrual symptom and calcium are related. That when they give calcium to women that have severe premenstrual syndromes, they get less severe symptoms. So this is something that probably needs some research done, if that is done. As patients, we definitely have noticed that we have severe PMS symptoms. And during menopause, premenopause, things can be complicated. But there's no studies out there currently with hypopara.
Yeah, generally, I think menopause needs more research in all aspects.
PMS and hypopara.
So it's very fortunate we have so many questions. We will be running out of time, but we have a few left. Parathyroid scans, what is their use? I think maybe that's just more diagnostic for hyperparathyroidism and also in the planning of parathyroid surgery to avoid hypoparathyroidism. Because if you know that you're a hyperactive adenoma is just on one side, you can spare the other and your risk of hypopara is practically zero.
So in hypoparathyroidism, we don't scan the parathyroids.
Yeah.
One question also, we have 2 minutes to the break. Is it common for symptoms to get worse over time? No symptoms for the first 10 years after diagnosis, and the last 10 years have been getting more and more severe. So do you think it gets worse? Symptom-wise, not I mean, we have the effects on the kidneys, of course, that we know, but symptom-wise?
It's not the first person I've heard this happen to, and it's difficult to know. I don't have an answer to that why, but I've heard about it. I think also as we do get older, maybe that there's other stuff that comes into consideration because of maybe the calcifications, because maybe we have more stress in our life at a point in time. Maybe there's something we're doing that's going to use more of a nervous system that can make that point in time make the symptoms worse. I don't know, but it's not the first time I've heard this.
Tanya?
Yeah, well, it can be that you have one parathyroid gland back that's working a bit, and then by age it might work less. So we sometimes see patients that are diagnosed with hypoparathyroidism actually maybe 10 years after thyroid surgery, and that might be that they were just capable of keeping the function in the first years, and then as time go by and they age, every organ ages in the body, and so will it. So that could be an explanation.
So I'm afraid we need to close for now. We want to be punctual, get our coffees, and get back on time at 11:35. I say thank you very much and see you later. Tanya?
Yeah.